All right, Pam, let's really open up.
Let's do
You
it.
ready? You ready to open up? You
Always.
have a lot more experience in doing orthodontics in the mouth. Okay. You have a brother that's an orthodontist. You're like me, medicine and dentistry is in your bloodline. I go back generations. So, but what I do have a lot of experience is working with orthodontists. Some good, some bad. And they do a great job. They do a needed job. But things are changing and changing fast. Bicuspid extraction was the norm 30, 40 years ago. So let's open up. Let's be real and
Oh
start
boy.
with that one hot topic, bicuspid extractions.
God, I love you brought
I'm
this.
laying it on you, babe.
Oh, we're gonna get roasted on this one. By we, I mean me, probably. All right, but you got my back always. All our listeners and viewers, if anyone says you need to have four teeth pulled in the middle, four bicuspid teeth extracted, do not do it. Don't do it. That is a red flag. When you pull a bicuspid, which are the teeth in the middle of your dental arch, that is about a centimeter in width. That's a ton of space because you have to remember it's a centimeter on each side. And the reason why once upon a time this became so common is because it simplified the orthodontic treatment and it made it go faster too. So as a business model, it was practical and smart. Now, what we're learning that, excuse me, to me, is the kiss of death. It is when you pull four teeth to straighten teeth, you're condemning a patient to a lifetime of possible TMJ pain and obstructive sleep apnea. Now, I have patients in my practice that are in their 60s and older, shoot, in their 30s and older that have had this happen, and not everybody suffers. If I wasn't there to be part of the diagnosis, I don't know everything, but I can tell you 90+% of my pain patients are four bicuspid extraction patients that, are really suffering from some type of TMJ issue and or sleep apnea. So when we have like 20 millimeters or 2 centimeters of space on both sides to our listeners, it allows the orthodontist or the dentist to, when we pull teeth, we gain space and then we could straighten out rotations in the teeth and then make the dental arches look really nicely aligned. But in doing so, we're also retracting, meaning pulling the teeth back. And when the teeth get pulled back on people who already probably have a deficient maxilla where the face is already set back, then you further push the lower third of the face, the mandible back. That's why the joint gets compressed, as you guys know, and the airway becomes constricted in the back. And that's why people end up suffering. So, in today's literature, even this year in the Journal of Orthodontics, they still write that for bicuspid extraction does not cause TMJ issues. I don't know where they're getting that information from. I personally completely disagree. It's not, it's impossible for it not to set people up in a bad position, but maybe they just don't suffer or hurt yet. It's just, to me, it's a matter of time.
So two things. One is that just because you had bicuspid extraction doesn't mean you're going to have horrible, horrible issues because the body can adapt.
True.
So then working with an orthodontist, like I live in a little rural area, and if my orthodontist believed in for bicuspid extraction, I had some that did, my only choice is refer my patients out 100 miles
Mm,
to get away from that type of thinking, to
right.
go to somebody that expanded things instead of retracted things. And I go back to the analogy we talked about in one of the other podcasts is that, if you were going to build a waiting room 10 by 10 and all the chairs were in perfect alignment, carpenters messed up, made it 9 by 9, the chairs would come in jumbled. So if you don't have proper airway, which we talked about in your book in craniofacial development, if you don't have the proper tongue molding the maxilla, then the maxilla is going to be a 9 by 9 instead of a 10 by 10, and the teeth are going to be crooked, teeth for the
Right.
chairs. And so it's a lot easier for the orthodontist. I mean, it's all about easier for the orthodontist. Of course, it takes less time, therefore cheaper. But it's a lifetime, a possible lifetime of misery, especially with sleep apnea. You retract everything, and you're retracting the back of the throat as you're retracting the front of the mouth. And I had one patient, a good friend of mine, and had his dad was a dentist, but he had four bicuspid extractions. He was very famous. He was the announcer for one of the major basketball leagues. And he said, "Yeah." I said, "When I had my four bicuspid extraction, it looked like somebody took a shovel and hit me in the face."
Oh, so true.
And that's horrible because it pulled everything back instead of coming forward to be natural.
Didn't the author James Nestor, the book Breathe, which I
Yeah.
think is incredible. It's in my whole team's read it. I recommend it to all of our listeners and viewers right now. But wasn't he a four bicuspid extraction case?
Yeah. And we're talking about, number one bestseller, New York,
Yeah.
New
Yep. Been on
York
Joe
bestseller.
Rogan. His
This is
story connects with so many people. And he's not a medical doctor or a dental doctor. He's an anthropologist and he studies the human face. And his whole thing was, what happens when we have to breathe through our mouth, whether it's because the jaw's retreated or you have some kind of nasal obstruction. It's an amazing read. I totally recommend it for our listeners.
So he was also on Joe Rogan's podcast
Yeah.
and they discussed all this. And so I took the URL, the link to that, and put it on one of dentistry's biggest social media platforms. They have over 200,000 dentists on there worldwide. And the orthodontists went crazy that I was being political and I was doing all this subversive stuff. Me do subversive things in dentistry. Who would ever think? So we have the dentists fighting dentists on this, the orthodontists fighting the general dentist fighting the dentist. So only way to protect yourself is for the listener is to be educated. And that's what our podcasts are doing.
Can I just put some energy out there real quick that's got nothing to do with our listeners? But if anybody from Joe Rogan's camp is listening to this, we need to be interviewed on your podcast
Yeah.
because he has a much bigger reach and we just want this content out there for our listeners. I mean, you have your book, Mac, the life robbing pain of TMJ. This is our passion out there. So if we can get our voice heard on a broader scale, bring it on. So if you're listening out there, connect with us. Now,
So,
back
so Pam, you think the two of us could do a good interview with Joe Rogan?
well, of course I do. I
Yeah.
hope our listeners feel that way too. But so going back, we got to open up. We're always a little bit spicy, or what I like to just say is being honest about it and not being afraid of saying things that are not ill-intended, but it's just true. My brother, like you said, he's an amazing orthodontist. He does whatever philosophy it takes to get people feeling well and them in a good bite. And we have a lot of debates and conversations. We have a wonderful relationship, but anyway, one of my biggest concerns about the specialty of orthodontics is that their protocol is to start evaluating children at the age of 7. And I think that's way too late. That's way too late. We're missing such a growth opportunity. And I understand that sometimes waiting later in life might make it a little simpler for parents to go through because it's not as time consuming. But about 90% of craniofacial development is done by the age of 10 years old, more than 90% actually. And what about those children who have sleep disorder issues? I mean, they're not breathing well at night and their mouth breathing all day. They are not getting nitric oxide to the brain. They're getting misdiagnosed with ADHD or sleep issues or even brain tumors, as I told that story in one of our other previous podcasts. And to some extent, these kids are almost becoming almost brain damaged. They're not getting the opportunity they deserve. Imagine, listeners, that if you had to breathe through your mouth all the time and you slept poorly, what kind of mental fog you'd be in. Imagine like being completely sick and your nose is stuffed up all the time. You're not clearly thinking, you're in a fog. And that's what these kids are constantly suffering from that grow into teenagers and then in adults. So, going back into like the delivery room, making sure that the babies are born without ties, making sure they're able to latch, not having any oral pacifiers or thumb or finger sucking habits. And parents, this is not to create alarm. If your children are doing this, don't panic and feel awful, but maybe try to nudge them into better habits, get away from those things. Um, and then I think once they're past that infancy phase, start looking at the kids as early as 2 or 3. They're different oral appliances. If the children will tolerate it and the parents are willing, that if the face is already starting to develop in a negative pathway, you can redirect and get that jaw and the face developing in the right way. Because my passion project now is to get kids' faces developing the right way so we never have to do braces and adults don't have TMJ and we can slow this pandemic epidemic of sleep apnea and TMD. So I wish my orthodontic colleagues would start seeing patients younger. And that's where being a family practitioner, a generalist, has been one of my greatest advantages because I see the parents when they're pregnant. I coach them through their pregnancy. I coach them through their child's infancy. I see them when the babies are born and reassess to see if they have ties. And then I monitor their craniofacial development through their journey in my office. I have the privilege of doing that, but orthodontists don't. They rely on general dentists to refer them out. And when? Around the age of 7. And that's later than
So,
ideal.
so what we're doing right now is heresy, dental heresy, because
It is.
when I went to dental school, all I wanted to do was get out. And all the gunners wanted to go to orthodontic school and oral surgery school and periodontal school and go 2 more years of absolute trauma. So when I approach an orthodontist and say, hey, I don't believe it. No, let's just revisit this four bicuspid extraction. They say, no, look, I'm the orthodontist. I'm the one that had 2 extra years of training, 2 extra years of training by people who know nothing about TMD.
Mhm.
You ever think about that?
Totally.
So if TMD is not taught in regular dental school, it's not taught in the graduate level either.
So true.
So yeah, we're committing heresy. Of course, I'm retired and I'm not going to get in trouble. So no.
Well, and
But
also,
this is, but when I refer my patients to a specialist, they are still my patients. Now, I cannot, by law, tell the specialist what to do because they're the ones that are supposed to know. But what does a general dentist do when they know more than what the specialist knows? Now, this is really opening up, and this podcast is telling it like it is. But you and I know that retraction, it may be 1%, 2% of the time it's needed. I have no clue because I'm not an orthodontist. But you and I see what happens to adults when they've gone through orthodontics that are incorrect.
right, because we grow old with our patients. We
We're
have
the
to
ones
over
that,
and over and over again.
yeah. So they take those teeth, like you said, and make those beautiful models where the teeth are all straight, but they're over closed and they're jammed back. They don't see them again. We see them.
Right.
And that's what my book is about, so that they can understand how the joint gets pushed back when the maxilla is deficient.
Well, let's click down a little bit further on that too, because, in orthodontic protocols, we're supposed to take an image, which is usually two-dimensional, and do something called a cephalometric analysis that measures the size of the person's jaw in comparison to the size of the teeth, like what they'll have space for and what they don't. And then when we're done with treatment, we're supposed to take another x-ray to check the roots of the teeth and make sure the roots of everything look good and they're upright and not tilted, etc. Where is the training on, we're looking at the teeth, but what did we do to the joint? What did we do to the airway? Because we could look at these pretty straight teeth on a model. We can look at our before and after photos of beautiful smiles, but can we look at somebody three-dimensionally and keep in mind that aside from these smiles, there is a human being attached to that mouth? And what has it done to their joint? And what has it done to the airway? I mean, I don't think any doctor is ill-intended. I don't think people can go to a medical or dental school with the intent of wanting to do harm. But I
No,
do think
no,
that
not at
people
all.
don't know what they don't know. And if you don't have the equipment and start looking at it more of a 3D global approach, it's not just teeth walking in the door. There's a human being attached to it. And again, one of the luxuries, if you will, or privileges of being a general dentist, a generalist, is that we get repeat patients. They come into our office year after year after year, and you really get to see if what you've done has worked or not, and what your colleagues who you referred out to has worked or not. And you get to look from that experience. That in and of itself is giant. That is what makes you become a stronger and better clinician, is seeing if what you did has worked and has stood the test of time.
So if I do a procedure on a patient and it works, and I do it again and it works, and I do it again and it works, and I do it again and it works, versus doing a procedure and it not work, which you and I have had our share of that, you got to scratch your head about what's right and what's not right. So they say to me, Mac, we're another dentist, a TMD dentist, where is your science? My science is I know what I do works. And you know what you do works. And we do the same thing. And both of it works for me, it works for you, it works for all of our friends at ICMO. So just to be a little bit more controversial, if you don't mind, do you
Never.
mind me being a little bit more controversial? So in dental school, there's three classifications of jaws, correct?
Mhm.
Class one, class two, class three. All it just makes such sense. But every one of those classes are models sitting on a table.
Yep.
So you have class one, this is a beautiful bite sitting on a table. Then you have a class two that's the jaw is back, and then you have a class three, the jaw is forward. But those are models sitting on a desk.
Right. Of teeth.
They're not of teeth. They're not in action. There's no action. There's
Right.
no opening and closing. There's no grinding back, sideways to side. There's nothing but sitting on a table. And that's what the orthodontists go for. And general dentists too. I'm not just bashing the orthodontists. I'm just asking for them to be more open to new ideas, which you and I went through that experience of being more open. To treat TMD, to do orthodontics, you have to be more open to what's out there and what makes sense. It
It-
makes sense for the jaw to be full. It makes sense to bring things forward and not bring things back because of the throat and the joint. It just makes sense.
I bet it makes more sense to our listeners than it does to doctors.
100%.
Seriously.
The, the patient can read my book and read your book and say, I understand that. And by the way, if you don't remember the title of the book, just
How many times have you heard,
put
how
our
come?
name in the Amazon search and the book will come up, and that's all over the world. But yes, patients totally understand this way beyond what the dentist did because the dentists have previous learning that prevents them from new learning.
So, I had a patient, and this is not the first time it's happened, but I've had a patient say to me, why should I come to you instead of going to an orthodontist? I was like, well, you can. What are your goals? Most people seek my treatment out because they are aware of the open mouth breathing issues. Most of them have had a history of TMJ issues themselves, and they don't want that for their children because they're still suffering and figuring that out. Um, and it always goes to the patient, our listeners. If you go to a doctor and you just want straight teeth, because again, let's face it, at this point, anybody can straighten teeth. No disrespect to orthodontists or dentists, but computer programs can straighten teeth. Remember, there's that Smile Direct company that went under, that people were straightening their own teeth at home. But you don't know, it's not just about straight teeth. You don't know what it's doing to the physiologic function of the jaw, where it's positioning the joint and what it's doing to the airway. And that's when people can get in trouble. But if you want to go and just have straight teeth, most dentists and orthodontists can do that to some extent. There are things that are outside my wheelbox. I don't do any surgery. For adults that are no longer growing, there's only so much we can do to help their mid-face deficiencies. So some people have to go and have surgery, like an MMA procedure, maxillary mandibular advancement surgeries. That I don't do surgery, so I don't really know how to set up patients for that. I don't want to know everything. That if I try to do everything, I'm not going to be great at anything. So those are people that I'm going to send to an orthodontist, typically my brother, so he can set those patients up for surgery. And then if those patients still have TMJ issues, but their airway is now corrected, then they come back to me to help them with their TMJ issues. So, a generalist, to our listener, a general dentist is different than medicine. A general dentist can do everything under the scope of dentistry, whether it's orthodontics, implants, wisdom teeth extractions, gum grafts, dentures. We can do anything under that giant umbrella and at any time we want. It's up to the general dentist if they want to go after their postdoctorate education to further their knowledge base on whatever becomes their passion. So I could choose to do nothing but orthodontic treatment in my office as a generalist. I can
Right,
do, right? I can do just root canals as a
right.
generalist. That is underneath my license, that is what's allowed. So, I just want to clear up that confusion. It's like, should a general dentist be doing orthodontic treatments? Absolutely, if they know how to do it and understand how to diagnose correctly and treat it correctly.
And you get to choose like root canals. You mentioned root canals. I did very few, but I think it's because of my fees. My fees were $1 million a tooth, and I didn't get.
That's why you retired. You did that last
I
root canal.
mean, there's some things, that you just don't like doing. So, and we're not bashing the orthodontist. I'm not bashing orthodontist. I want the orthodontist to listen because they don't live where we live. They don't see the patients that we see. They don't have in your questionnaire, have you had four bicuspid extractions? Because, like you said, we see so many TMD patients that have had it. So please, we're just asking you to listen. We're just asking you to listen to learn more about what Pam herself knows from her own personal experience in treating these patients, starting at a very young age, which is just fantastic.
Yeah, agreed. Look at kids younger, see fewer patients, charge more, so you have the ability to have the equipment and the time to spend on these patients. And make sure each person is treated uniquely to their needs, and then
And
have a protocol to make
we
sure
had
they
a whole
don't fall backwards.
we had a whole podcast on why treating TMD is expensive because it takes time. You have to listen. You have to spend a lot, tons and tons and tons of money on training for the benefit of the patient. So,
Yeah,
yeah,
understood. All right, my friend. Always a good conversation with you.
always exciting.
All right,
Later. See
bye.
you later.